Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed. I am here with Andrew. It's just the two of us this time. It's been a while. And I have a question for Andrew, which is, how's it been going on the teaching service?
Yeah, pretty good. Pretty good. Yeah, first time back in a couple months, so it's nice to be back with the residents. Rootviz, James, and Sakshi are listening. It's a great week. I put up a little Twitter thread and kind of the fun takeaways we all had together on service. A lot of good clinical reasoning, and yeah, it's been good, Mike. Been good to be back. How you been?
I've been good. Glad to hear that you're having a good time on teaching service. I'm also having a good time. We actually have some pretty great cases right now that I hope will probably find their way into one of these sessions. But no promises. Sometimes it is really just something very boring.
Oh,
But I think I've got a few.
just spoiler for the listeners. Mike texted me the other day saying, "Hey, I actually have an update on the severely elevated transaminosis case that we presented. So stay tuned. It sounds like we may have some more atypia going on, and we may circle back to that."
There will be a part two.
Yeah, we have something different today, Mike.
I have something completely different. Shall we get into it?
Yeah, let's do it.
We have a 55-year-old gentleman. He has a history, interestingly, of only lung nodules. He has cocaine use disorder, and I think that's it, actually. He is coming into the emergency department for failed antibiotics, outpatient. He's being admitted for IV antibiotics per the primary care doctor who's sending him in. I actually want to stop there for a second and just hear your thoughts, your approach to antibiotic failure, particularly with respect to cellulitis, which is what this patient is coming in with. That's the presumed diagnosis.
Oh, okay. Yeah, I was just about to ask you. It sounds like they've got on antibiotics for something. I was trying to find a syndrome to attach that to. It sounds like it's cellulitis, and we'll definitely, I'm sure, get more history on that momentarily. But I think antibiotic failure in general, there's a really great schema by the clinical problem solvers on this, where it's basically considering wrong drug for kind of the bug that you're treating. So you consider, okay, maybe this patient was considered to have kind of a typical bacterial infection for cellulitis, your kind of run-of-the-mill gram positives, gram negatives, staph, strep, these sort of things where you presume in the acute setting these are kind of the usual culprits, so you put them on routine antibiotics for this. But if it's not one of these routine kind of bacteria that you see, just the routine gram positives, gram negatives, and something that's more chronic that requires a whole other different treatments, then of course the patient's going to fail in terms of their antibiotic treatment trajectory. So that's one consideration. Another consideration is kind of like source control failure. And I think kind of tied into that is, are the antibiotics you're giving going to actually penetrate the space that you're trying to kind of get to? So, if this is a skin and soft tissue infection that's complicated by endocarditis, and there's an abscess on the heart valve or an abscess somewhere else in the body, that's going to kind of cause perpetuated sort of infection. And those patients probably, unless if you remove that nidus of infection, are going to kind of behave similarly. But if things don't metastasize and they stay kind of like local to the skin, like the original source, and there's an abscess there and the antibiotic you're giving doesn't penetrate into the abscess, that's going to be a big issue too, of course, right? Because then it's just going to be undertreated. You consider needing to IND, or incision and drain those lesions to actually drain out the bacteria at that site. So those are the first two considerations that kind of come to mind for me. And then kind of the last pillar for antibiotic failure that's kind of considered, or just like treatment failure in general, is the patient just hasn't had enough time to kind of respond to the antibiotics. And that's typically seen in kind of more invasive sorts of infections. They're just they take a malignant kind of trajectory, so you kind of expect them to take several days to improve, but you're intercepting them too early in the treatment course, or the treatment you gave them actually will cause them to acutely worsen. The classic example being the Jerish-Herxheimer reaction of syphilis, where they have this acute distributive shock sort of picture after you give them the appropriate antibiotics. So those all come to mind, but it sounds like it sounds like a pretty healthy guy. I'm just so curious to hear more, Mike, about kind of what was going on with him, and yeah, well, what did he say when he came to the hospital?
Absolutely. So thanks for that. I just figured I'd give you the bare minimum so I could hear that that schema you have. I'm gonna actually send you pictures of what he's coming in with, and then while you're taking a look at those, I'll just kind of give you an idea of what um, he is going through these last what's really been actually almost a month and a half. So they're coming in now. Basically, he's actually been dealing with this for about a month and a half. This is his bilateral shins. So he basically developed these about a month and a half ago. He actually came in to have them seen in the emergency department, where they did find a fluctuance. They lanced it, expressed pus. It just grew staph epidermidis. And they said a biopsy, actually, which just showed an abscess, essentially, just neutrophil debris, and read as abscess. He was prescribed Keflex at that time and sent on his way. It did not get better. And so he went back to, I believe, an urgent care, was prescribed doxycycline, which he took, I believe, for 10 or 14 days, one of those two. Relatively longer course, though. And he failed that as well. This thing's actually progressed since then. Both of these things have progressed since then. Um, they're pretty painful. And so he's really coming in because the pain is getting worse. And yeah, Andrew, I'm wondering how you would describe these lesions. We'll put them on the website for those for listeners to take a look at, but just how you're thinking about these lesions on his bilateral shins.
Ooh, I'm gonna be very far from classic dermatologic descriptors, so bear with me. They're two lesions that look like they've been around a while because you see that they're quite large. Like, I don't know if I'm using the right scale here, like 2 centimeters maybe, like in size. So they're pretty big, and they look like they've been kind of necrotic, like a lot of the epithelium just like gone, and you can see the kind of subcutaneous kind of tissue there, and you can kind of presume that that's been opened up before and it's kind of just exposed now, and it's kind of failed to heal. And just to clarify, so this is when you're meeting him now, and he's really coming back just because they look like this, but they're very painful still. That's kind of like why he's coming in now. Is that right, Mike?
That's absolutely
Okay.
correct. Yep.
Okay. Yeah, yeah. So you get this impression they've kind of been drained before, and that's kind of what you're seeing, is that kind of like exposed, sort of like subcutaneous kind of um, area. And they're red. They're quite erythematous, both centrally and peripherally. And honestly, at the edges of one, even looking a little kind of like violaceous, I would say. The clinical significance of that, I'm not quite sure right yet. Um, One of them, the one that's more open, looks a little bit more like a chronic wound that maybe could be associated with like a chronic infection. The other one that's like less exposed, I kind of see these like little dots around it, and it kind of reminds me of like a net. Like if you were to, in terms of like a nets like sort of pattern, that's kind of what it looks like to me. But yeah, definitely very angry. I could see why he's in a lot of pain. So, okay, I think this all makes sense, like why he's here after the treatment failure, right? So he got like standard non MRSA treatment at first with the Keflex, you said, and then he got the MRSA coverage on top of that, presumably because it grew pus before, it was purulent. So there's suspicion for MRSA, and that's when you escalate to MRSA coverage in terms of your management. And the doxycycline, you expect this better penetration actually into abscesses. So we're thinking that would do a good job, but he's still here. So it seems that we're dealing, if this is an infectious etiology, with something that's going to be kind of non-routine. So we're talking about like atypical sort of bacterial infections or non-bacterial infections. But I really think that that hypothesis is tempered. I mean, going back to our kind of like red leg discussions from a couple episodes ago, I mean, this is bilateral, right? So we've been talking about infection for the first 10 minutes of this because that's kind of what they tell you when he's coming in from clinic. But I mean, these are bilateral lesions, and the probability that that's infectious is quite low, kind of off the bat. This is not someone who Mike taught us if you have kind of like chronic skin disease, you can have superimposed fungal infection. His legs look completely fine other than this. So I think that makes the probability of infection quite low. So just thinking of other things that can do this. You know, autoimmune diseases can cause, these acute inflammatory skin changes. Again, I don't have that kind of descriptor yet that'll help me make progress. But I would say whenever you hear kind of like bilateral skin lesions, often people think paniculitis. This looks like more than paniculitis because paniculitis, I believe, just kind of stays very tender subcutaneously. It forms a nodule, it gets red and angry, but it doesn't express pus like this and really form into these kind of like mass forming lesions. When I thought of characterizing this as kind of net like appearance, I think of pyoderma gangrenosum, which is um, something that we've talked about in a prior episode. And that's not an endpoint diagnosis. We'd have to solve what that is. But that's something curious to consider in terms of what could be driving a neutrophilic dermatosis. But beyond that, you think of local cancers. I think less likely since it's bilateral, um, and uh, yeah, those are kind of the first things that come to mind. Yeah, I'll pass it off to you, Mike. Yeah,
Fantastic. I feel like what I'm hearing is, infections are obviously common, but the bilaterality of this is makes that much less suspicious, and then that sort of invokes what I'm hearing from you is sort of thinking about systemic diseases that would be able to hit both legs. So um, I think that that's the way to approach the case. It's, I think, the good starting point there. Um, I wanted to give you a little bit extra, which is that when you're talking to him, he's coughing quite a good bit actually during the exam. Again, he's here just for his legs, but you just notice that he has a cough. And he says, "Oh yeah, no, I have been coughing for a little while. It's been going on, but it doesn't bother me that much. I used to smoke cigarettes, and I think I just have a cough from that for a long time. And kind of, I'm here to get my leg figured out. Leave the rest of this alone. Don't go poking for things." And so I should mention he's a relatively well appearing gentleman overall. Definitely a bit younger than stated age. He is afebrile. His vitals are not consistent with sort of SIRS, sepsis. He has no leukocytosis. He has a very mild anemia at 12, which appears to be new from labs a year ago. And platelets are the same as last year, which are normal. Chem 7, LFTs, all of that's basically all of his basic labs are within normal limits. There's no abnormalities. Um, I think he has an ESR and CRP, which both of which are elevated. ESR is 78, and the CRP looks to be 112. And that is, I'll leave you with that aliquot to hear how that might
perfect.
change the thinking on things.
I love it. My first response to the patient, unfortunately, I don't think I can leave his his cough alone. I'm sorry. I'm sorry, sir. I'm sorry. So I think the issue with my discussion last aliquot, which was very like rambling, that's an inexperienced internist approach to like an inflammatory skin lesion. It seems like what would I do next in that situation? I should have mentioned the last aliquot. You really at that point you take a full review of systems to see if we're thinking this is something systemic. What else can you kind of collect and kind of add into your problem representation to maybe make your job a little bit easier. So I think your observation that the patient is coughing a lot without a clear explanation, that lends itself to the idea that there's something going on, perhaps inside of the respiratory tract. And you can start like from the top in terms of common things, postnasal drip, all of these things. But when you're invoking systemic diseases, none of the interesting stuff really lives kind of in the oropharynx, with the exception of like sinusitis of like some vasculitis. Really, the meat of that is inside of the lungs. So I feel like if we're really trying to get to the bottom of this, we need to understand what's going on with the cough now. So, cough, non-specific, top to bottom. But I think getting probably not just chest X-ray, which is pretty insensitive for small lesions that can still be culprit lesions for cough, but cross-sectional imaging of the chest will be helpful next, just to see what's going on inside of there. It'd be helpful, if you're in the clinic, how um, how worried should he be about this patient? Some red flags for cough are like dyspnea, hypoxemia, hemoptysis. So it'd be helpful to hear if he's had any of those symptoms accompanied by that and know his vital signs. But it sounds like he's not that concerned about it since he's saying it's been going on for a little bit. And quick question, Mike. You said he uses cocaine. Does he inhale cocaine, or does he just or does he only snort cocaine, or does he also smoke crack?
He generally snorts it. He smoked crack a few times, but actually nothing recently.
Okay, got it. Okay, very good to know. Yeah, so I'd say taking a full review system, see if there's anything else going on, and get some chest imaging to see if anything's going on in the chest, and we can kind of go from there.
Sounds great. So he has nothing else, excuse me, on review of systems. I will say he's probably, I don't want to assume, but seems to be minimizing symptoms. And yes, we can definitely go ahead. You're able to convince him to stay for the night, to get some chest imaging. You do explain to him that this is probably going to take more than 6 hours in the emergency department to figure out. He is started on IV vancomycin, and he actually got a CT of the extremity, and then I'll also give you the CT of the chest. So the CT of the lower extremity shows complex collection within the superficial soft tissues, as described, most compatible with phlegmon or early abscess formation. The borders are ill-defined and measures approximately 3 centimeters to 1 centimeter in depth. And that was just on we went for the right lower, which was the one that looked a little bit more meaty, the one that looked more like an abscess, with that sort of central punctate lesion. And then the CT chest. So he's status post left upper lobe wedge resection in 2023. So I had mentioned that history of lung nodules. He had a lung nodule that was resected and showed necrotizing granuloma, no tuberculosis or MTB or NTB, excuse me. And that was kind of, it was lost to follow up, but it didn't show those two things. It didn't show malignancy. And so he was lost to follow up. So it shows the fact that he's had that wedge resection. And then nodular consolidation, smaller, and some new since the last scan, which apparently he's had a scan 2 years ago, low dose CT scan, new foci of internal lucency cavitation and surrounding ground glass opacification. For example, a focus in the right upper lobe nodule consolidation is contracted with a new cavitation in the adjacent nodule. There's new area of nodule consolidation in the right middle lobe, mild emphysema, no pleural effusion, and there's no other abnormalities aside from those that I just mentioned. So he has essentially multiple nodules, consolidated nodules that have cavitation, and they have changed in character since his low dose CT scan 3 years ago, 2 years ago, I guess it is.
Wow, things are picking up now. Okay. This is I finally feel like I have something to kind of bite on now. So I think we could ignore the leg for a second, just talk about like cavitary lung lesions, which really represents kind of necrosis. Something is like eating away at the lung tissue to kind of get rid of that tissue and cause these air-filled spaces, right? So starting with hypothesis number one, kind of similar to the skin lesions, a lot of people will jump to infection first as a cause of that. Local necrosis of lung tissue by something that you inhaled. For example, if you have alcohol use disorder and you're chronically aspirating and you have a nidus infection in the base of the lungs that kind of bruise and bruise and bruise, you can have like polymicrobial with anaerobic bacterial destruction of lung tissue, and it can cause like a very, very large local lung abscess, right? Tuberculosis, that's mycobacterial mediated destruction of lung tissue, accompanied by the necrotizing granulomas, which Mike mentioned was in the prior upper lobe tissue, the location of which being important because, of course, TB often kind of like reactivates and cavitates first in the upper lobes rather than the lower lobes. So if things are more focal in the lung from an infectious standpoint, if it's not just kind of this polymicrobial abscess from aspiration, but a routine organism, it's usually like Klebsiella, Staph aureus, Strep pyogenes. Those are kind of the ones that cause focal cavitating lesions. This is a case of multifocal cavitating lesions, it seems. So, still being with hypothesis number one, this being an infection, you consider metastatic infections, right? Most people go first to the heart valves and thinking, does this patient have right sided endocarditis where they're flicking off vegetations all throughout the lungs? And that those culprits are most often still the routine culprits like Staph aureus and all the ones I just mentioned. That can do that. Endovascular infections beyond the heart valves can do this, as in Lemire syndrome, like Fusobacterium species can do this. Strep anginosus species can often do this in the absence of endovascular infection. For whatever reason, strep anginosus is one of this groups of bacteria that just like to stick everywhere and go everywhere, even without a heart valve defect or an endovascular infection. So those are kind of the most common bugs I think of, and kind of syndromes that can cause metastatic cavitating lesions that are related to infection. But let's bring the leg back in. So if we're bringing the leg back in, we're already saying this guy already failed antibiotics, right? And there's stuff going on. It sounds like maybe this has been going on a lot longer than the patient has been saying. Because if we're saying that the lung nodules are actually progressing, like they weren't just incidental nodules and now there are new nodules. If I heard correctly, they think the old nodules have actually progressed. So that would suggest this is very much a chronic disease, very much non-infectious. This would be very, very strange for an infection to go untreated like this and for him to survive. I think it's very unlikely at this point. So now we have to go to kind of the non-infectious differential for cavitary lung lesions. So cancer is very common, right? Like we see squamous cell carcinoma of the lung do this as a primary, but of course this is metastatic, so we're not thinking that's the case here. Um, Certain lymphomas can do this. Lymphomatoid granulomatosis was a CPC we had at BI last year that I learned about that can do this. But we're not given any sort of like constitutional symptoms, lymphadenopathy, anything like that can do this. And uh, I think the one disease that really comes to mind is a GPA, autoimmune disease. So a lot of autoimmune diseases can touch the lung, but very, very few of them actually do cavitary lung disease. That one is really GPA. So GPA is granulomatosis polyangiitis. It's an ANCA-associated vasculitis. You can test for it with an ANCA screen, and that reflexes to an MPO and a PR3 antibody. And my kind of illness script for that is chronic sinusitis. People come in with a lot of sinus pain, frank epistaxis from destruction of the mucosal tissues in the nose, and then subsequent hemorrhage, hemoptysis from cavitary lung lesions like this. And these things can progress. I had a case at Yale of very severe cavitary lung disease from GPA. In med school, I had a case of a person who presented with shoulder pain, found to have a large upper lobe cavitary lesion, biopsied, everyone thinking was going to be tuberculosis, was GPA. So it's very sneaky, but it's helpful to know because again, a lot of autoimmune diseases can touch the lung. Like think of all of the idiopathic interstitial pneumonias, like NSIP. So many different autoimmune diseases can touch the lung, but cavitary lung disease is really like GPA. So I'm certainly going to be testing for that. in him. Certainly, tissue is going to be the issue here. Sorry, my brain is all over the place. Another reason to bring this up is the necrotizing inflammation seen on the prior lung biopsy. That's already super helpful because if we're saying that this has been around a while, it's probably the same process going on, right? So I think we already have this hypothesis. Okay, this thing has to kind of cause granulomatous inflammation. I think um, to pull in his history, I think the cocaine use may end up being helpful. The cocaine is often contaminated by a medication called levamisole. Levamisole is one of these causes of drug-induced ANCA-associated vasculitis that you can see, and it causes a lot of different autoantibody positivity, and that can present with necrotizing lung inflammation and skin disease, just as in this case too. So I think we're certainly going to be sending the ANCAs as a non-invasive test for this patient. I wouldn't be surprised if another bronchoscopy biopsy is done of the tissue to kind of retest for bacteria, both typical and mycobacterial, getting the AFBs, the TB PCR. But I think it's honestly going to be, it's very unlikely. It's unlikely it's going to be one of those things based off the chronicity. And uh, yeah, if I didn't say it out loud, the the way the skin disease can present with vasculitis is it could all be sterile pus. It sounds like something cultured in the past, which is not uncommon. If you have some sort of local skin inflammation of any reason, even if it begins sterile, it can always get super infected and you can develop super infection. And that will fool you up front into thinking, okay, this is a routine infection. But now that we know it's treatment failure, we may even reframe that initial issue as, okay, maybe it started as sterile pus and then it got super infected. And you can see this with untreated vasculitis. The same patient I said earlier who had raging cavitary lung disease, she actually had a breast quote abscess, which it was an abscess. It's full of neutrophils and pus, and it's painful and it needs to be drained, but it never cultured anything, and it kept happening. She actually had another subcutaneous abscess that developed off treatment too. Um, but yeah, Mike, I'm hoping you'll give me some ANCA soon. This is a very interesting case. What did I miss? What's next?
Just let you go there. That was fantastic. I'll give you, if it's okay, I'll give you the biopsy results. I'll pause, see if it changes any thoughts on your end, and then I'll give you the other tests after that.
Yeah,
And that'll be the final aliquot.
yeah, sounds good.
All right. So the lung biopsy. So this is the right, there's actually one in the right upper lobe. So we went for that one. Well, I didn't, but the pulmonology team went for that one. Um, they basically, it shows actually pretty non-specific. It says lung tissue with fibrosis and acute on chronic inflammation and necrosis, negative for malignancy. AFB is negative for microorganisms. A culture is sent, which also does not grow anything, and including TB cultures. At this point, I was waiting to present this case to you because I wanted to make sure that nothing turned positive on those cultures. But I think we can say now it's been many months with no growth. And then the skin is also biopsied. I will say that it was very hard to get a biopsy of this. Everybody who saw it was worried it was pyoderma gangrenosum, and you don't want to cut into that. But we finally found a dermatologist who was willing to biopsy it a second time. And it showed, let's see here, deep dermal abscess with acute on chronic inflammation and necrotic granulomatous tissue. And then also routine cultures, fungal, mycobacterial, all of those things were sent a negative, no neoplastic changes identified.
Interesting. Before I comment, I'm just going to pull up. I haven't used my notes so far, but I want to pull up a script for something I'm kind of keeping in my back pocket that I want to just be able to comment on. I just want to make sure I have the pathology right for that one. Um, mm, 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 mm. Okay, interesting. All right. So these are non-specific findings, and I think it's unsurprising. It sounds like we missed maybe in the lung some of the granulomatous inflammation that we're expecting, and maybe we just captured some already kind of necrosed tissue, and for whatever reason we missed the granuloma. So I don't think we kind of get too much out of that, and I think we're confident with the prior biopsy, or rather cultures for AFB and kind of the clinical history, it's not TB. So I think we kind of ignore the lung. The leg, did you say it was a granulomatous reaction or granulomas, Mike? I'm not sure if they made that distinction. I'm not even sure if that is a distinction.
It just says necrotic granulomas.
Granulomas. Oh, okay. Got it. Got it. Got it. The only other thing to add to the differential from the last aliquot I mentioned, in terms of autoimmune diseases that can present like this, there's something called aseptic abscess syndrome, where you can form abscesses kind of all over your body. And I have the script in front of me here. Apparently, in terms of the distinction in pathology, um, of this compared to the traditional neutrophilic dermatoses, because if you think of neutrophilic dermatosis as just infiltration of neutrophils in the skin, and you say, okay, there's this different entity called aseptic abscess syndrome, which again is just abscesses. How is that different? My notes say that these deep abscesses in aseptic abscess syndrome are surrounded by a granulomatous reaction, which is absent in classic neutrophilic dermatoses. So I guess in terms of the consultant's concern that this is pyoderma gangrenosum, which is a neutrophilic dermatosis, I think that's less likely since we see the granulomas here. And yeah, I don't think it ultimately changes anything for me, Mike, since we already knew there was necrotizing inflammation. I still think the next best steps kind of lie in the blood work in terms of assessing for the ANCAs and looking for vasculitis. And if that is the case, then considering a trigger for that being the levamisole and cocaine. But if that doesn't pan out, then we have to kind of speak again. But I would start with that because I think it sounds very consistent.
All right. So, final aliquot. You run those tests you mentioned. So the ANA is negative, but the ANCA is positive. He has a C ANCA positive. His proteinase 3 antibody, anti-proteinase 3 antibody is actually negative, and his anti-myeloperidase, peroxidase, antibody is positive. Um, his complement levels are normal, and those are the tests that were sent. And I will mention that his screen on admission was positive for cocaine. I'm going to pause there. Obviously, I'll have some reflections, but I wanted to hear just your thoughts on that, aliquot.
I love it. I think we have our answer with this, and this is really nice because it's a non-invasive test, which comes back pretty quickly at where I'm at now. I think the ANCAs come back in like 4 or 5 days, which in the grand scheme of things is like not a long time when you're considering like the other option for things being quite invasive, like repeat lung biopsies, which have risks, right? But no, we have the positive ANCA screen, which then reflexes typically at most institutions to the MPO and the PR3 antibodies, and you kind of use those antibodies because they correlate with these different ANCA associated vasculitis entities, like uh, GPA correlates with PR3 positivity and typically a C ANCA pattern, and MPA and EGPA typically associated with the MPO antibody, which I believe is the one you provided. So here's the conundrum here: those associations aren't perfect for those. They can kind of cross with each other in terms of their association. But I would say, with how strong the clinical picture is here for cavitary lung disease, that really goes with GPA. We're not seeing that antibody line up nicely. Like we would want the PR3 antibody for that one, kind of for a final answer. So I would just say, given we know this guy has a chronic history of cocaine use, and this has been going on a while, and any sort of adulterant, any sort of exposure to the body that can cause kind of a multitude of autoantibody positivity, it often causes these kind of non-elegant antibody responses where things don't really make sense. And especially if you see many, many different antibodies come back positive at once, that should automatically kind of trigger that there's something the body's being exposed to, either exogenously, like an adulterant in this case, or endogenously in the form of some sort of cancer that's kind of driving this. So yeah, I think this is a case of levamisole probably adulteration, and cocaine causing ANCA-associated vasculitis, causing lung necrosis and kind of skin necrosis. And Um, I haven't seen a case of this before. So, Mike, you probably have a lot of teaching points lined up. I hope I'm right on this. Don't tell me I'm wrong on this, Mike. What are you going to teach us about?
No, you're spot on. I mean, we don't have weren't able to send blood work that showed um, the levamisole, but we sort of presumed it in this case. I mean, I actually don't have that much to add because you nailed it and you discussed so much of this through this case. Um, One thing I thought was interesting is that in the levamisole induced ANCA vasculitis, it's more common that you have discrepancy between the oncotype and whether it's the anti-proteinase or the anti-myeloperoxidase. So, like you said, right, there's these kind of classic correlations, but the rheumatologist in this case actually said, and I'm actually just going to read it out to you. C-onca should correlate with anti-proteinase 3 antibodies for serologic diagnosis of GPA. C-onca with anti-myeloperoxidase antibodies, as seen here, could instead suggest levamisole-induced ANCA vasculitis, which can more commonly manifest with necrotic skin lesions. The cocaine then supports that diagnosis. So yeah, that was really the thing that, because when I saw this, generally it's sort of like my understanding was if you see that, then it's oftentimes a false positive or there's a testing issue. But actually, no, in this case, it's kind of something that we see with this specific thing. So, yeah, I found this case to be fascinating. I had not heard of this mechanism before. And apparently, it is in like 75%. What was it? 70, excuse me, I think it's, yeah, 70% of the cocaine supply in the United States right now is contaminated with this. So basically, I think you can presume that anybody who's using cocaine is probably being exposed to this. And so generally, this is a little bit abnormal. It tends to actually show like the classic is like retiform purpura with like hemorrhagic bullae. That's actually like the most common presentation, and usually it is on the forearms, but actually most cases have on the ears. You see this on the ears, which is very interesting. We can throw a couple case reports in the website, but so that was a thing that didn't fit. And the I think what was also interesting about this case, or I thought cool from like a clinical reasoning standpoint, right, is that you're just sold so hard in the ED, both from sort of the presentation that you're told over the phone coming down, but also the patient, right? He's like, hey, just take care of my leg and send me home. Right. So it's that I know that will influence the way all of us see a case that may otherwise feel very straightforward if you're just reading it on the boards. Right. So, and he actually, unfortunately, has not followed up with any appointments since then. So, he has no follow up. He was not treated with steroids, which is the treatment for this. He ended up leaving, against medical advice before we could initiate treatment. And some of this stuff actually came back after he left, including the ANCA. So he didn't leave knowing the diagnosis, unfortunately, but this stuff came back later on. So I thought it was interesting, and thanks for listening.
Yeah, that's really tough about the outcome though. Funnily enough, the patient with non-adulterant induced just native GPA I saw in residency, she actually had a very complex kind of relationship with healthcare and kind of was off treatment for 6 months, and her disease like really took off therapy. Unfortunately, because things got worse, she did end up coming back and eventually did get on treatment, kind of. So I'm sure he'll come back at some point. When he needs a little bit more help. But people have complex relationships with us, and yeah, it's tough, but we're always here for them if they need to come back. But no, I would just while you're talking, Mike, I pulled up some old notes from all the way back in med school. So that case I mentioned of the upper lobe cavitary lesion that I saw presents for that shoulder pain found, thought to me malignance. Here's some fun facts about cavitary lung disease for the listeners. So it's classically thought that the measurement of the thickest cavity wall is the most useful tool in predicting malignant versus non-malignant cavitary lesions. That to say, if you have a cavitary lesion with a very, very, very thick wall, this paper I read with a cutoff of greater than 15 millimeters, they say that it's malignant 90% of the time. And then cavities with a wall thickness of less than 4 millimeters is this lower cutoff. It's mostly non malignant 94% of the time. And then if you're between 5 and 15 millimeters, it's rather mixed. So we were really blown away with the case that I saw because it was kind of one huge, very thick one in the upper lobe. And then he had like two really small ones in the other lung fields. So it wasn't really framed as a case of systemic disease, even though it was multifocal. It was more framed as cancer because they were like, this thing is just so big and so thick, it has to be malignant. But no, he had GPA. If you just add in those two little small cavitary lesions, and suddenly it's like, okay, actually, no, this is a systemic disease. I think this case was pretty obvious. I think that's how I got there. I mean, other than me having it's not that recent anymore, but some recency bias of seeing this case twice now. I was able to distinguish it, but I think also there's a very prominent signature here in the lungs. It was just like very clear to me, and that was so helpful because not knowing that information, not knowing about the cough prior to the skin lesions, I was stuck. So it's just funny how we solve problems and how things can change in a moment's notice like that. Beyond that, let me see. What else did I pull up here? I'll just comment. Definitely going to go up on the website, but and I was kind of alluding to this in a very uh, roundabout way. Is the autoantibody stuff that was going on in this patient? So, Mike, I don't know if I've ever talked to you about this before, but I call this kind of unelegant finding autoantibody craze, where you have this kind of variable autoantibody positivity. It doesn't really fit a classic illness. Some early clues that that may be going on for a patient is polyclonal hypergammaglobulinemia, because you're literally having something trigger the output of numerous autoantibodies, and that's what you're seeing on an SPEP. A positive rheumatoid factor is often seen in these cases, and in terms of the consequences of that, this is a perfect example of a case of that. This was vasculitis as a result of the ANCA disease. So these different diseases can cause actually autoimmune diseases, not just the autoantibody positivity. It leads to disease in some people. And then some other tip-offs you may be dealing with something related to this phenomenon, autoantibody craze, is just B symptoms and lymphadenopathy. And I already mentioned exposures can do this. I think I left out infections can do this. I'm sure at some point we'll, on this podcast, come across a case of like tuberculosis or syphilis doing this. We saw this on the Klatskin service in Ben Chipkin's case. And then malignancies can do this, I mentioned. Particularly a lot of lymphomas can do this. So I'm sure we're going to circle back to this topic a lot. I love this topic. There's no name in the literature for this, hence my fun naming of this autoantibody craze. But that's all I got, Mike. I'll drop it on the website. Super cool case. I'm glad I could finally get one of your diagnoses right. I feel very good. I'm working on my my accuracy rate of my case is just very poor right now. So thank you, Mike. I appreciate you.
You were as soon as you heard about the lungs, you were right there.
Yeah. See you, man.
All right, take care. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.